Thank you. Thanks everybody for attending. Thank you to Zomedica for hosting this. We're going to talk about GDVs today. The goal here with this talk is to make it as practical or clinical as possible so that you can actually use this information in your own practice, especially if you see GDVs or even operate on them. I do have proceedings available if desired that go into way more detail than we're going to review here in case you wanted that more nuanced information. Otherwise, it's meant to be a pretty practical discussion. Any and all questions or comments are welcome. This is our outline. We'll start off with the prevalence of the disease, followed by reported risk factors. We'll talk about the etiology, the pathogenesis, clinical signs, diagnostic, stabilization, treatment, surgery, and then post-op complications, mortality factors, what kind of outcome you can expect, and then some final key points before we have any questions. And a lot of this information, again, for practices that see GDVs, this is common knowledge, but just to make sure we're all on the same page, the prevalence of this condition, it's pretty common, 2.4 to 7.6 for every 1,000 dogs admitted to a hospital. And we do see a slight predisposition towards males. They typically are middle-aged to older. They are reportedly 39 kilograms is what the average is. And of course, the breeds, German Shepherds, Great Danes, Standard Poodle, any deep-chested large breed dog or extra large breed dog are prone to gastric dilatation and volvulence. There are a ton of risk factors reported in the literature. I collected the ones here that I feel maybe make the most sense because some risk factors are perhaps associations, not necessarily risk factors, but advanced age, large breed, dogs that eat a low number of meals per day, their temperament, mostly being anxious temperament, a family history of GDV, a history of splenic torsion or having a concurrent splenic torsion, a history of splenectomy, and this has an incidence of 3 to 8%. Having a splenectomy performed prior to developing a GDV, it's a 5.3 times risk factor for that. So it begs the question, if you are performing a splenectomy for any reason in these dogs that also are known for splenic neoplasia, liver neoplasia, do you PECSI them at the same time? And gastric foreign body, if they have a foreign body present, 5 times increased risk. And then sexually intact animals. Now, the etiology, despite how common this condition is still not clear cut. Again, the literature is filled with information and theories on what may cause GDVs. Is it that the stomach bloats first and then twists, or is it a twisting of the stomach and then followed by bloating? It's difficult to say. The thought process is with deep-chested dogs that there is more room for the stomach to be mobile and therefore predisposes them to a GDV, whereas the smaller animals, not so much. And for whatever reason, we don't know really whether that's as simple as that or whether it's a ligamentous issue. Is it a eating behavior issue? We don't really know. I have seen chronic cases, what I call chronic GDVs, chronic bloaters. So I do divide them into acute and chronic. Obviously, the acute or paraacute are the most common presentation, but I've seen dogs where they literally walk in with a GDV. They're completely stable. The owner brought them in for abdominal distension, and they're doing fine otherwise. And you take your right lateral radiograph, and you have a GDV, and the patient is stable. And if you probe these owners further, they will usually point to intermittent time periods in the past of abdominal distension in those dogs. And I'm convinced that some of these dogs bloat at home and then detours themselves and they're fine again. And the owners never know any different. So I do call them chronic bloaters. Also, what I've seen with again dogs I suspect chronic bloaters is intraoperatively, I actually will see not only will their small intestines be hypermotile, hyperperistaltic, but also I'll even have the stomach distend in real time in the OR. And I don't know if folks who are listening and watching this resonate with that, but I do see that propensity to re-bloat literally in surgery for some of these dogs. And then the question of primary condition, versus idiopathic. So we frequently will call this idiopathic because we don't know what causes it. And it seems at the time of operating these dogs, all they have is a GDV. However, you are talking about dogs that are middle age to older and large breed dogs. And so they do frequently have comorbidities. And I have seen cases where the dog came in for a laryngeal paralysis a week prior, was medically managed, and then had a GDV presented to me. I've had dogs that I found a lung tumor during the workup for a GDV. I've had dogs where I found a liver tumor during the workup for a GDV. And you wonder if conditions that can potentially affect their breathing pattern, like a lung tumor or laryngeal paralysis, does that make these dogs more prone to Ireifej and then GDV? So I'm convinced, and have always hoped of conducting a study to look at whether or not these dogs actually do have some sort of primary condition that predisposes them to GDV. Lactate concentration over 6 millimeters millimoles per liter is considered 88% specific and 60% sensitive for diagnosing. Then average rotation is 180 to 270 degrees. So this really is considered a systemic disease. It's going to affect the entire body, and you're going to see as the stomach enlarges and torses, hypertension, caudal vena cava compression because of the abnormalities in blood flow. The blood supply to the intestines may be compromised, and so bacterial translocation resulting in bacteremia can be seen as well. Then, as the disease progresses, the portal vein becomes compressed. The liver then becomes bacteremic. The pancreas will get roped into the stomach just by the anatomy, as you can see in the picture there. And so pancreatitis is a concern. And the stomach compromise can be seen in somewhere between 10 and 37% of these cases where the vascular supply of the stomach has been inflicted. And then, of course, because of anatomical reasons, the spleen, I have had hemoabdomens associated with rupture of either the vasculature to the spleen or the spleen itself. And then, of course, through the end stage of this condition, if it's not treated, coronary flow is affected. So you can see 40 to 70% of these dogs have arrhythmias during the disease and as it progresses. We all are aware of the clinical signs. Here's your classic presentation: large breed, deep-chested dog with an acute onset of abdominal distension, non-productive retching, drooling, pacing, seeming restless. And so for those of us in practice, you've probably, if you deal with dogs and cats, you've probably seen this in dogs in your practice. Now, stabilization is a bit more involved discussion, which we can have if folks have questions about it. I'm going to break it down to just very simplistic, as kind of reminders. Fluid resuscitation is the hallmark treatment of choice to try and stabilize these pets. They are intensely hypovolemic with the GDV, and because of its acute or periacute onset, the body does not have time to correct those, and so we need to get involved. Now, there are more and more literature now talking about low volume fluid resuscitation for critical patients, not just GDVs, but any critical patients. And that's true with dogs and equine papers that I've read. And so we'll see if this becomes more mainstream in the future, to, instead of large volumes of fluids getting in these dogs as fast as possible, maybe a more titrated fluid resuscitation is indicated. We'll see as the papers come out further. The idea there is that fluid boluses are not without its own set of concerns, of risks. So hemodynamic stabilization is the goal. Ideally, at least 2 large bore IV catheters are placed in these dogs. And then whether or not you decompress the stomach before anesthetizing them, or during the anesthesia, or as you're rolling into the OR, it depends on surgeon preference. The picture there in the bottom left, that's showing trocarization, which has been shown to be positively impactful in these dogs. I, for one, don't bother with it. There's a risk, of course, of gastric rupture, let's say, if you place the trocar in an area of the stomach that's been compromised. But My argument for that is going to be, if it's already that compromised and you're going to surgery anyway, you're going to deal with it at that point in time. These dogs aren't going to be decompressed with a trocar and then waiting for surgery a day or two later. And in the meantime, they may have gastric contamination into the abdomen. So I'm fine with trocarization if you want to. The literature does support it, although I would argue more literature is needed on that. I, for one, as a surgeon, don't. I prefer to have the patient decompressed actually in surgery as I'm opening the patient up. So all of us who have dealt with GDVs have had to decompress them. And if you have a dog, like if you see the picture in the top right where they have their hands over the muzzle and there's medical tape in the dog's mouth. If you have a dog that's so obtundant from hypovolemic shock, circulatory shock, you can sometimes do this without any anesthesia or any sedation. You could pass an orogastric tube. So dogs that are really critical like this, they come to your facility in bad shape, and you want to decompress immediately, then you can place the medical tape in their mouth, and then the orogastric tube can go in the middle of the hole there to decompress the stomach. And like I said, these are only dogs that are pretty obtundant. You have the tape there in case the dog does happen to wake up or become more alert so they don't bite the tube. In the top middle picture, you can see them pre-measuring the orogastric tube. Typically, you're aiming for somewhere around the last rib. And then my technician there on the other two pictures in the bottom, he's got the stomach pump. And so we're in the OR with the orogastric tube placed, and he's pumping water into the stomach and then suctioning it back out. And this is what we do. The reason why I decompress them while I'm in surgery is because those of us who have tried this know that the distal esophageal sphincter can be a huge barrier to trying to pass the orogastric tube into the stomach. And I find that if my technician, while I'm in the operating room, is passing the orogastric tube, meanwhile I'm detorsing the stomach, that actually helps release the pressure, obviously, of the stomach as I'm detorsing it, and then they could pass the orogastric tube into the stomach, and then I use the orogastric tube to evacuate gas, fluid, dog food, whatever's in there, before continuing on with the procedure. So I use it in that manner, but obviously, if it's a matter of life and death, of course, most of us are going to decompress them before going into the operating room. Now, in regards to surgery, there is some nuance when it comes to whether or not you resect the stomach. So the bottom left picture shows a focal region of the stomach that's probably not going to be revivable. You usually, when you feel that area of the stomach, well, first you look at it and it's got that black or dark purple color, and then when you palpate it, it's very thin walls compared to the rest of the stomach. It also feels almost kind of leathery. We've all experienced that, the sort of dead skin aspect. It feels like that. And if you can't palpate vessels in that area, those are all the different signs you're looking for to determine whether or not it's viable. So you may want to perform a partial gastrectomy. Now, I've dabbled with the idea, and I know folks do this where they won't do the gastrectomy just yet. They'll pexy the dog, and then day or two later re-explore them to see if the stomach has healed up, because as we know, those of us do a lot of surgery, a lot of gastrointestinal surgery, the body can surprise you, and sometimes it'll come back. I have not done that, and for me, I'm trying to minimize anesthetic episodes, so I'm going to operate them the first time around. Of course, I warn the pet owner ahead of time that a gastric resection may be indicated, and do I have permission to do so? The reason why we try to avoid gastric resection, as you'll see later, is it does contribute to morbidity and mortality in these dogs. So it's ideal to not perform it. And I certainly can say from my own experience, gastric resection definitely debilitates these dogs. For some reason, I'll say, it really just causes a problem. And then the spleen, you can see in the top right, there's a large engorged spleen. We have to decide, is the spleen enlarged because of thrombosis, in which case a splenectomy is indicated? Is it enlarged because there's torsion of the spleen, or is it anesthetic related? Is it the body trying to compensate for being in shock? Is it a normal size for that dog? And so a judgment call has to be made. My main goal with this, assuming you don't have an obviously ruptured or torsed spleen, or a spleen with like a tumor on it that's found incidentally at the time of surgery, um, you're going to palpate the blood vessels and see if there is blood flow into the spleen. And if there is, leave the spleen alone, perform your gastropexy, and then revisit the spleen and see what it looks like and see if it's cleared up. It's a large vascular organ, so hopefully, if it is compromised temporarily, you'll see the improvement as you progress with the procedure. The drawing on the bottom of the stomach there just shows an example of what a gastrectomy looks like. It's as simple as an excision, and like I say, would like to avoid it, but if it's necessary, then it's necessary. There are a variety of different gastropexies that have been evaluated, and most of us, of course, perform the incisional gastropexy that we'll review in the next slide. But these are just some examples, and the literature is pretty clear on what's the strongest based on research studies there. For me, again, just the simplicity and the speed of an incisional gastropexy is the way to go. But I'm sure there are folks who are listening and watching this that perform other types of pexying. I would not advise pexying the stomach to the linea. That to me just is, you're asking for trouble. If the dog has to have an abdominal exploratory in the future, you're going to undo that surgery, best case scenario. Not to mention maybe cut into the stomach, but whatever technique you're most familiar with that you've had success with, of course, is the way to go. And then I don't perform laparoscopic procedures, but just for those who are interested in this or who already are performing it, I want to make sure that folks are exposed to it. Typically, this is done as a preventative measure. You wouldn't treat an actual GDV with laparoscopic gastropexy. That's an open procedure. But for dogs where you're going to spay them or neuter them, or they're down for a dental or whatever it is, for a dog who's also an at-risk breed for the disease, you can perform laparoscopic gastropexy. And the picture in the middle shows the grasping instrument as it grabs the stomach through a small, minimally invasive incision. And then the end result is on the right side there, a nice looking gastropexy. The incisional gastropexy is what I'm performing and probably what the majority of folks are performing. You want the adhesion length to be somewhere between 2.5 to 5 centimeters. It's going to be pretty standard, right? Because these dogs are all going to be similar size. They're all large or extra large dogs. You're rarely going to do this in a small breed dog. The gastropexy site should be around 6 centimeters oral to the pylorus. Mean surgical time report is just over an hour. And you can see in the drawings there what the goal is: incision, and then have the meat. Now, in regard to the location being 6 millimeters oral to the pylorus, I don't really measure it. For me, it just depends on where the stomach sits most naturally on the abdominal wall, because you're going to be in the OR with a large breed dog. It's a large body cavity. You're probably going to have balfours or some sort of retraction of the abdomen. And not to mention there's probably ileus, and that's also going to be taking up space. So you want to make sure that the stomach pexying is going to be with minimal to no tension on the abdominal wall. And so wherever that manual contact is going to be, that's where the incision is going to be for the gastropexy. And just as a reminder, if you do have retraction, like self-retracting Balfour retractors, remove them when you're trying to figure out where to make the incision. And then once you feel on the stomach where you're going to make your cut and on the corresponding abdominal wall, then place your Balfours back in if you want to. But I usually don't, because I want this to be as natural as possible. So once I'm done my exploratory, stomach's been detours, I do my explore, and then I'm going to remove the Balfours to not only measure where I'm going to make my cuts, but also to actually make the cut. Now, there are studies that are pointing to the lack of need to make an incision in the stomach, which is great, because then you won't have any accidental penetrations into the stomach lumen. But more importantly, because that's probably a very low incidence, more importantly, it'll speed up the procedure. And so that's pretty cool. So if we'll see what the future studies show, but if the dogs actually form a permanent adhesion without entering the stomach, great. That's even better. But for right now, this is the standard procedure if you're going to perform an incisional gastropexy. Monitoring. So Obviously, this is a systemic disease. These dogs require monitoring 24/7. This is not an outpatient procedure. And if your clinic does not offer overnight care, I'm going to presume you probably are transferring the case to the ER. If ER is not even an option, I'm assuming that the pet owner is going to watch the dog overnight, but then bring them back the next day at your clinic for reevaluation. Whatever it is that you and the pet owner can do, fine. But the ideal scenario, in my opinion, is going to be 24/7 care, which means monitoring is going to be potentially intense, especially in a dog with multiple comorbidities who came in pretty debilitated from the condition. So we're all familiar by, with using our eyes and our ears and feeling things to examine these pets, especially post-operatively. However, of course, these are subjective measurements. So the idea of using devices like pulse ox and blood pressure machines is that they're very objective. And so if they're objective, it gives us a clear, do we have to react to this or not? And if so, how much? So the objective measurements is ideal. Of course, you're using it in combination with manual, but the idea behind equipment like Vet Guardian is telediagnostics. We, as a veterinary field, are really behind telediagnostics. It's like 20 years behind. And on the human side, they're using this. These diagnostics have been used, and I do know it's going to be the future for veterinary medicine as well. Remote monitoring, whether you're talking about remote in the hospital or remote from somebody's home or clinic, is going to be more and more common. And we are seeing products like this come out. So I love this machine. It measures vitals on the pets, and you can see from the picture in the bottom right, it's thermography based. The picture up top shows you that you can have multiple animals being monitored at the same time. Just goes to your tablet, your iPad. Body temperature, pulse rate, respiratory rate, movement, all based on thermography. And yeah, it's a telediagnostic tool, like I said, and there's 24/7 access, storage, auto updates, all that stuff is what we're looking for in a device like this. And you might ask, well, why would you use this in a GDV? Well, a couple of reasons, and in no particular order. Number one, the staff. We all know that if you're in ICU, they're dealing with not just the one critical patient, they've got several, and there are also incoming patients that may be critical. And so technicians, assistants have to step away. Devices like this allow you to monitor the pet continuously without having direct eyes on the pet or the machine. It should be alerting you for any abnormalities. And so you basically have a virtual assistant who can monitor these pets. Additionally, the pet is going to benefit. A lot of these dogs are large breed dogs that are arthritic. They are going to be pretty sedentary on a good day, and they're going to be just not only have undergone a major operation in a debilitating condition, but you're going to have them probably on narcotics for post-operative pain. It's going to sedate them heavily. You don't really want to keep interacting with these pets over and over again. They need to rest. They need to be able to recover from the procedure, but you also want to monitor them. And so this allows you to handle these animals less, especially the ones that get worked up, or if they're aggressive, you want to make sure you can monitor them without putting the pet or the staff at danger. And the clients understand this. This is a huge benefit to the practice because it makes sense. Telediagnostics are the norm. You're seeing that with blood glucose measurements at home for our patients, right? The owners can monitor their pets' blood sugars, and so this is no different than trying to do that. Try to take the diagnostics up to the next level. So continuous waveform Doppler radar technology for this. Oh, good. Here. So this is a close-up. Just a very nice, clean interface. That's the point. And multiple animals up top there. So it's a nice interface. And those of us, this day and age, this technology is common, right? We all have smartphones. We have smart devices. So it can be hooked up to various devices as well. Now, complications of GDV, and this is one big reason why I'm advocating for 24/7 monitoring at a facility that has overnight care, because these complications can be detrimental. And overall, a 76% complication rate is insane. And that's because it's a systemic disease, and these are patients that have comorbidities. And you can be the best surgeon in the world and have all the tools, all the staff, and the dogs we're subject to the dog's biology. So Acute renal injury can be seen in 3 to 8%. Disseminated intravascular coagulopathy, 8%. Cardiac arrhythmias are the most common, in my experience as well, reported to be 30 to 50%. Splenic thrombosis, 3%. Peritonitis, 5%. Recurrence, 0 to 15. And, I tell pet owners the recurrence rate is virtually zero. If there is a recurrence, assuming that surgery went well, I'm going to do a workup for these dogs for endocrinopathies, neoplasia, immune-mediated disease. I'm going to tell the pet owner there's some reason why this dog did not heal from what otherwise should be a curative disease, a curative surgery. So that's my initial discussion with them. I also want to touch base with DIC, just a little bit of a tangent, because I do hear a lot of confusion regarding coagulopathy. So just to be clear on it, if you're seeing petechiation or ecchymosis on a patient, that indicates that's superficial, right? That's not body cavity. That's superficial. You can see it on their gums, on their skin, and that indicates a problem with stage 1 of the coagulation pathway. So that's the platelet plug. And if you have ecchymosis or petechiation, that is one of 3 reasons: von Willebrand's deficiency, thrombocytopenia, which means the platelets aren't working correctly, or thrombocytopenia, which means you have an insufficient amount of platelets. That's it. There's no PT or PTT testing when you're talking about ecchymosis and petechiation. Whereas if you're talking about actual blood accumulation in body cavities, abdomen, thorax, joints, then you're worried about the issues with the second stage of the coagulation profile. And that's where the clotting factors are a problem. And of course, there's many different types of coagulopathies in this category. And that's where the PT and PTT come in. And so that's where you're going to focus on that. And then DIC is specifically, in quotation marks, specifically a third stage of the coagulation pathway with a problem with a clot breakdown, clot formation. So that's where you're looking at the D-dimers and things like that on a coagulation profile for DIC. And of course, there can be overlap. You can have more than one coagulopathy, of course, and something as complex as DIC could affect the body on multiple levels. But I just want to make sure that distinction was clear when you're thinking about how to categorize these coagulopathies in your head. One more thing I'm going to mention here, before we move on, is the cardiac portion. So you can see there in the top ECG, those 2 big arrows are pointing to a VPC. On the bottom, you can see ventricular tachycardia. There's a run of VPCs. And the question often is, well, how often do you have to monitor these dogs, and when do you treat a VPC or any heart arrhythmia? But we're going to focus on VPCs for this. So in my own experience, what I've learned over time is I have 2 rules for when I'm going to treat a VPC or VPCs. One is the patient is being affected by it clinically. They've got pale gums, they're weak, shortness of breath, their pulses are weak, their pulses aren't synchronous with the heart. Those are clinical signs. Syncope, those are clinical signs of a dog that's affected by ventricular arrhythmias. And so I'm going to treat those dogs. My second category is if I see in a stretch of ECG 30% or more, 25 to 30% or more of the ECG strip are VPCs, I'm going to treat regardless of whether or not they're clinical for it. Those are my 2 rules. Those are my own rules. That's what I've done over the almost 20 years of this, and that's when I treat them. The importance about having continuous ECG as opposed to spot checking is that you can miss VPCs. And I'm convinced that when these dogs do great, they go home, they come back for the recheck, they're great. And then like a month later, they drop dead at home. No warning, no nothing. And I have a feeling that scenario is either thromboembolic disease or it's a lethal arrhythmia. That's my thought. And so you can't monitor these dogs' heart rates forever or heart rhythms forever, right? That's not realistic. But the important thing is, at least in the immediate post-operative period, monitor them continuously if possible, if not every 6 hours. And you want, maybe a minute-long ECG evaluation before you consider it. None of it's perfect. These things can still be missed, but that's how I tackle VPCs. And then finally, when I am going to treat VPCs, I'm starting with usually a lidocaine bolus. And if they convert, meaning if the VPC or the VTAC resolves, then I put them on a CRI. I start the low dose of the CRI for lidocaine because lidocaine itself can cause neuromuscular weakness. It can cause ileus and nausea. and these are already, and of course it's an anesthesia, it's an analgesic. So you have an older dog that's already compromised, and I have all these side effects of lidocaine. So obviously the benefits of normalizing the cardiac rhythm outweighs the side effects of lidocaine for these dogs, but you want to start low dose because they are going to be affected by it in good and bad ways. And then I move up that CRI, tending towards the maximum dose, depending on how they're responding on the lidocaine. While I have them on lidocaine, you can see on the bottom right procainamide. Now, I have not used procainamide injections myself, typically, or sorry, or anything IV. But typically, if they're going to be on a lidocaine, if I'm seeing arrhythmias, then they're going to go on procainamide as well. And I start at the same time as lidocaine, intramuscular procainamide, and then they go home on orals. And I treat them for 2 weeks after surgery until I see them for the recheck. More of a safety measure really than anything. And then I do check the ECG one more time at that 2-week recheck to make sure that things look good. Obviously, that one spot check doesn't represent the entire 2 weeks of recovery and beyond, right? But it's the best you can do, practically speaking, until we get more telediagnostics for home use. I want to bring up bronchopneumonia. So these dogs are going to be older, large breed dogs. They're going to be sedentary, and they're going to be laying around in the hospital a lot. And if they're really that down and out, it's going to be hard to get them out for walks, put them on a gurney, and roll them outside to go urinate and defecate. So they're going to spend a lot of time in recumbency in their cage. And that predisposes them to not only pulmonary thromboembolic disease, but also bronchopneumonia. And we all know that bronchopneumonia in any patient, especially an older patient, is very detrimental. So you see there on the radiograph on the left, ventral dorsal view of the thorax. There's consolidation of the lung lobe with a bronchogram. And then on the right side in the cranioventral region, which is the most common region to develop bronchopneumonia, we've got the same thing, pulmonary consolidation, air bronchograms, indicative of pneumonia. I am careful to not always call it aspiration pneumonia. If I don't have clear evidence that the dog actually aspirated, meaning that shortly after regurgitating or vomiting, the pneumonia began, then I'm not going to call it aspiration pneumonia. Pneumonia can occur hematogenously as well, for example. But GDVs, they're coming in for GI issues, and so vomiting and regurgitation is part of why they came in. And so it's not out of reach to call this aspiration pneumonia, but I just want to make sure, because we tend to overuse that phrase, that we know it means something very specific. Mortality factors. So the incidence of mortality is a wide range. And I also want to make something clear too, that these wide ranges are because these studies are very complex and they're all different. It's hard to standardize a condition as complex as GDV with all the different ways of intervention, both medically and to some degree surgically, but really more medically. So these papers are all over the place. So it was difficult for me to provide a synopsis. The proceedings that I have tries to do that as well, but keep in mind these wide ranges may be just a subject of how we're reporting the literature. Incidence of 10 to 68%, survival somewhere between 75 to 97%. If there's no surgery involved, 80% mortality, of course. These are going to come back, the GDVs. When how they present themselves initially, if they're in a coma, for example, or obtundant, that gives them a 3 to 36 times risk for having increased mortality from this disease. Needing a splenectomy does contribute to the mortality factors. Gastric necrosis, very severe, over 50%, and that gives them a 6 to 11 times risk. Lactate concentrations may be predictive of that, and your proceedings will have lots of numbers on lactate, and then various biomarkers are always being reported in the literature as well. So a few key points here. Prevention obviously is ideal. You want to have the conversation with the pet owner at the time of adopting an at-risk breed. And if you're skilled enough with laparoscopy and you want to sell that idea to them at the time of spaying and neutering, fantastic. If they're not looking to spay or neuter their pet, then for any anesthetic procedure, whether it be a dental or because they want to actually be proactive and perform the prophylactic gastropexy. So prevention is obviously ideal. You want to be able to make it so that if this dog was going to have a gastric dilatation and volvulus later on, that the pexy would make them, worst case scenario, have a gastric bloat, not a torsion, but just a bloat, because these dogs do probably have some inherent motility issues. And so you rather deal with a food bloat or a gas bloat than you want an actual GDV, right? That's better for everybody, not just the patient, but also for the client. Prevention is ideal. So you want to prevent it. Now, nothing wrong with providing a prophylactic gastropexy as an open procedure. That's what I would do. These days, more and more pet owners want the minimally invasive. They're willing to spend the money on it. And so it is the ideal, is smaller incisions, quicker recovery, but nothing wrong with doing open as well. It's better than having a GDV later on. So I'm fine with either one. But the point is, have a discussion with the pet owner at the time of acquiring that dog. Obviously the acute condition is going to be more common than the chronic. I reviewed what I consider chronic. I don't want anybody to leave this webinar thinking that chronic is an established thing in the literature. It's not. It is something that I've seen over time, and I hope that eventually, if not me, somebody will provide studies that hopefully can show that. It's a hard thing to show, right? Because if they self-resolve from a GDV, then and the pet owner has no idea, and you're not going to see the pet, and you're not going to be able to confirm or not. So, but anyway, acute obviously is the main focus, or periacute. Is it primary versus idiopathic? There's some reason why these dogs develop a gastric dilatation and volvulus, and I don't think we've dived into this as thoroughly as we ought to, especially considering how serious and common this condition is. I still call them idiopathic as of now, but if I do find comorbidities, then I'm suspicious about whether or not that's the case. And then the question, of course, becomes, if you find a primary cause, what do you do about it? Obviously, if there's like a gastric foreign body at the time of the GDV surgery, you're going to perform a gastrotomy and remove it. But what if the patient has a lung tumor? What if it has laryngeal paralysis? What if it has any other comorbidity? Along the same lines, what if they have a condition that the owner knew about that's elective, and they now want you to tackle at the same time as a GDV? And so this brings me down to that last point here, concurrent surgical procedures. So we've all had this happen where you're going to perform a life-saving surgery. It's a hemoabdomen or a GDV or whatever. And the pet owner is like, hey, by the way, while you're there, can you neuter them? While you're there, can you remove that mammary gland tumor? Can you remove those bladder stones? And so veterinarians often get frustrated by that question because we're thinking the priority is a life-saving measure. However, I would argue a better way to tackle this is to say, sure, I'm open to performing those elective procedures, insert the procedure name, if I am granted permission by you to abandon the procedure if the patient is not doing well under anesthesia. If I have any concern whatsoever during the surgery that performing this 20-minute cystotomy for the bladder stones is going to be a detriment to the pet's life, I'm not going to do it. And of course, the pet owner is going to agree to that. Why wouldn't they, right? And then you can always perform the procedure later after the dog's recovered from the GDV. So I'm okay with it to some degree, but I do preface it by saying to the pet owner, it's not ideal, but I want permission to be able to abandon ship, abort mission if I don't think it's the best case for the dog. Now, towel clamps is interesting. I put this here because I do know a lot of practitioners don't have valve floor retractors in their hospital. If you're performing abdominal surgery on large breed dogs, like Spays, for example, I encourage you to acquire valve floor retractors. It's a self-retracting mechanism that it holds the abdomen open for you, and so you, as a surgeon, can do your work while the abdomen's wide open. You don't need to have a scrub nurse or another doctor scrub in. You're wasting a staff member for that when the retractor can do the job. However, if you don't have a retractor, I understand. And what I've used in surgery is a towel clamp method. So if I can go back to the one intra-op picture, there we go. So if you notice there's two towel clamps, right? So if I take a towel clamp on that side of the abdomen and I place a towel clamp, these are sharp These are sharp towel clamps, and they're penetrating the abdominal wall and the subcutaneous tissue, not the skin. And I can lift up that abdominal wall. So being right-handed, I'll use my left hand to elevate the abdominal wall using the towel clamp. And then with my right hand, I'm suturing, right? And so the incision's already been made in the stomach, it's been made in the abdominal wall. I know where I'm going to have them meet. And now I'm holding up the abdominal wall with my left hand and suturing with the right. And that's a nice way of not relying on anybody to be in the surgery to retract for you. So I'll use that method. And I've done it on both sides of the patient, by the way. I've done it on the side, like for this picture, for example, I've done it on the side of the towel clamps, and I've done the pexia on the other side as well. Sometimes their bodies are so deep that I have to stand on the patient's left side, left side, with the patient in dorsal recumbency to try to do the pexy. And so I'll do it across the incision that way. But regardless, whatever works, I just want to give you guys some ideas there for a procedure like this. Delaying gastric resection, we mentioned that previously. I don't have any experience with that because I'm deciding whether or not to resect them right then and there. If it's obvious, if it's questionable, then I will wait, or even I'll call the owner's introp and say, hey, look, I'm seeing some signs that the compromised portion of stomach might be viable. I'm seeing some signs that it's maybe not. What do you want to do? If we leave it in and I'm wrong, we're going to be operating this dog again in a couple of days. If I'm right, then great. We eliminated that concern. And, you can talk to the pet owner, introp. I have them on speaker. My technician will call them and we'll have a discussion about it. So delaying gastric resection can be considered. I would say for me, it's delayed if the owner is on board and it's questionable. If it's definitive, then I'm going to resect the stomach right then and there. And don't forget, folks, you're not resecting the stomach to get margins. You're just resecting the part that's not vital, that's not viable, rather, right? So when you cut that cut portion, make sure you actually have bleeding on the edges of the gastrectomy site so that you're not suturing necrotic tissue into necrotic tissue. But you don't have to go wide margins. That's not the goal here. The less stomach you can remove, the better. And then finally, splenic biopsy and liver biopsy. If you're going to remove the spleen, right? If it's torsed, if it's ruptured, if it looks like it's got a thrombosis, it's compromised for whatever reason, it's got a tumor on it, biopsy it. You're going to submit it for a biopsy. It doesn't matter if it's obviously torsed and you're convinced there's no cancer there. These are the same dogs that get hemangiosarcoma of the spleen and liver. So submit the biopsy. The old age rule of if you're going to remove it, submit it. So submit the spleen. I don't mean splenic biopsy like doing a true cut or a wedge or something like that, leaving the spleen in. I'm only referring to if you remove the entire spleen, you're doing a total splenectomy, that you also do submit it. Yes, there's a cost for the client for that, but if they are diving into a GDV surgery, they're probably in the thousands of dollars. And so a little bit more for the biopsy is worth it. And then for liver biopsy, I biopsy all of my GDV's livers, even if there's no history of hepatopathy, even if the liver looks grossly normal, I biopsy them because, again, these are the same dogs that are prone to hepatic neoplasia. So I biopsy the liver. Obviously, if there's a concerned area or areas of the liver, then you're going to biopsy those, right? But if the liver is normal, then I'm going to biopsy them. And submit that to the lab as well. So that's what I do. I don't have literature to back that up. That's my own experience with it. I prefer to be on the safer side, of course. Again, it is an additional fee for the client, but I think it's worth it to do that. And that's it. That ends this webinar. These are my social media handles. Those who are interested. I've been doing live streams on YouTube for like a journal club type thing. So feel free to subscribe and tune into those live streams. And then that's my email if anybody wants to reach out to me. That's the QR code for Vet Triage. And again, I can't thank Zomedica enough. You guys are fantastic. Thank you for hosting this. I'm happy to take any questions or comments that folks have.